All, welcome to one more show. This is Dr. Mubin Sayed, and with me today we have our rock star that has been frequenting our channel before as well, Dr. Stephen Phillips. Dr. Stephen Phillips has a very successful and a long practice in chronic inflammatory diseases, especially Lyme disease and other chronic infectious diseases. So we'll discuss a little bit more about his work and his Substack and his book. First of all, let me welcome Dr. Phillips. Welcome.
Thank you very much. It's such a pleasure to be here and to spend time with you again. And yes,
Thank you.
that's correct. I been in practice since 1996, and we have one of the largest practices in the United States that's devoted solely to chronic illness patients. We specialize in vector-borne infections, things like Lyme, and many other infections that people have not heard of. And the ironic part of my story is that even though I'm in this field, I got taken down by an infection called Bartonella, and it almost killed me. I didn't walk for 2 years. I was not virtually bedbound. I was completely bedbound. I had 50-pound weight loss, a severe anemia, chronic fevers, 102 every night, saw 25 doctors, completely failed by the medical system, and came back out of that, clawed my way back to health, wrote a book about it, and have some interesting stuff to share about my observations about long COVID, people who've been chronically ill after vaccines, what we've done to help them. And I'd love to talk about Monolaurin, my favorite supplement out there.
Awesome. Awesome. Thank you very much. So very quickly then, let me present to the audience here. So KoolBeens, this is the book Chronic, The Hidden Cause of Autoimmune Pandemic and How to Get Healthy Again. This is by Dr. Stephen Phillips and Dana Parrish. Dana has been here on our channels as well. So this is one I have always requested folks to have this book. Have this book with you. Have this book for your family, especially the youngsters. Youngsters, if God forbid, end up in a chronic infectious disease state, sometimes their doctors, they do not even know what to do. So having this book becomes an alert for them, an awareness for them. So I am a big proponent of this book. I have no financial ties with Dr. Phillips or his books, or there is no kickbacks. This is just me believing that this is important book to have. In addition to that, this is Zero Spin. So, Dr. Phillips, can you tell us about Zero Spin?
Zero Spin is a newsletter that I started to share with people in-depth topics versus a broad stroke. The book is all-encompassing, and I wanted to have the opportunity to go down the rabbit holes really, really deeply on certain topics that I was interested in, like inflammatory cardiomyopathy, the infectious causes of that, and the infectious causes of MS, and evaluating how well do the current MS treatments work, and looking at potential causes of long COVID. And when I got to Monolaurin, I figured I'd write a happy little one-part article about Monolaurin, but it's such a versatile, broad-acting agent that it went into 4 parts. And it's, I don't have a supplement line. I don't have anything to market, supplement-wise. But I always said if I had a supplement line, it would be like a store that just sells tea, because I would just sell Monolaurin, because it's really the only supplement that I am so in love with and impressed by. And I'm always very, very disheartened on the times that it doesn't work for patients, but it works for the majority. I'd say about 80%. And it works in ways that are completely distinct from antibiotics, which I'm happy to discuss with you.
Excellent.
Okay, so for starters, Monolaurin, it's a naturally occurring substance in breast milk. Its mechanism of action is it works as a detergent. It gets in between lipid bilayers, and just like you wash your hands, you kill 99.9% of the bacteria, and same thing with the viruses and parasites and fungi. That's why Monolaurin has this incredible reach. But unlike regular antibiotics, it's been in breast milk for so many years that it's co-evolved with our microbiome. So whereas it kills disease-causing bacteria, it does not harm our microbiome. And in animal studies, it actually increases the the amounts of beneficial microbes in their microbiome. So it's so rare in medicine to get a win-win-win. It's cheap, it's safe, it's effective, and by the way, it helps your microbiome rather than hurting it.
That
And
is so interesting. Sorry,
and
please.
I'm sorry, I'm so sorry. And then in terms of the viral parts of it, it works against all the envelope viruses. So the the pharmaceutical antivirals that we have are very, very specific. They work against one or two or a handful of viruses at most. Monolaurin works against all envelope viruses. So all herpes viruses are enveloped. Epstein-Barr, cytomegalovirus, herpes, herpes 1, herpes 2, whatever herpes virus is out there has an envelope around it. COVID has an envelope around it. There was data came out in Nature where people in Italy from the first wave, those that had higher circulating levels of monolaurin in their blood did better than people with lower levels. And the viewers may say, how did they have monolaurin? Were they taking it? Maybe some were, but some other people can convert a little bit of lauric acid into monolaurin on their own, and this is variable between people. So some people are just lucky genetically, I guess, and can do that, and others don't do it so well. And monolaurin can conceivably work against even extremely serious viruses that have envelopes around them. Think of things like Ebola. No one is looking into monolaurin as a adjunctive therapy, these things, but they've done studies with influenza. They've done studies with many of the herpes viruses, and it's very, very powerful. And I can tell you personally, I've had patients who've been on Valtrex and other acyclovir derivatives for years for recurrent outbreaks, and as soon as we put them in monolaurin, their outbreaks either completely stop or diminish something like 90%. And I think this is really important in a number of ways, because herpes simplex 1 and 2, there's a lot of accumulating data that drives dementia. I don't know if you heard about this data with people that when they had, there's always been this link with herpes and dementia where they found a serologic association, and they've even been so far as to do these little mini brain studies where they took nerve cells in a test tube, it's a mini brain, put herpes into it, and showed how it makes characteristic changes of amyloid. And they've done studies of people that get at least 3 herpes outbreaks per year and treat them with antivirals, and show that the ones that took up to 4 weeks of antivirals had a 50% reduction of dementia years later, and the ones that took up to 6 months of antivirals, and again, they were looking at the Valtrex type drugs, had I think it was a 91 or 92% reduction of dementia years later, which is kind of crazy. And it should make front page news a lot of places, and no one's talking about it. So could the treatment of herpes prevent subsequent dementia? This is one of the many paths that we have that lead us to dementia. I mean, dementia is exploding in our population, and it's something I take very seriously. And anything that we can do to prevent it, an ounce of prevention in this field is not just like a pound of cure, it's like 1,000 pounds of cure. So if monolaurin works against all these herpes viruses, could it also help prevent dementia in a similar way to the Valtrex type drugs? Again, I'm just postulating, but I think possibly yes. And then I saw that you did a video just a few days about Candida auris.
Yes.
Which is such a freaky fungus and scary. Thankfully it's not that prevalent yet, but it's spreading and it's miserable. And I had just written about it in one of I think, which part of the Substack, I guess it was part 4 of the article on monolaurin, and the mortality rates are crazy high, even in the United States. It could be like 30 to 60%
or more. Yeah.
It's insane. So meanwhile, here we have monolaurin that has broad activity against Candida, and it, to my knowledge, has not been checked against Candida auris, but it's been checked against even fluconazole-resistant strains of Candida. It's been shown to work. It's been shown to work against Candida biofilms. Biofilms, for your viewers that don't know, are one of the chief resistance mechanisms of pathogens that are like the scourge of the medical science. The infections that we can't get rid of easily, they usually form biofilms. And biofilms is jelly-like substance in between the microbes, and it prevents the immune system and antimicrobials from penetrating. And there are very few things that are active against Candida biofilms. So Candida within a biofilm is roughly 1,000 times more resistant than Candida that's free floating. And it just has this tremendous potential that I think is not really fully evaluated because it's the age-old question. There's no money in it. It's a derivative of lauric acid, which is, from coconut.
Hmm.
Oil, if anyone will do these studies, but it's something I think that obviously should be done.
That's very interesting. So, Dr. Keith Berkowitz, who is also a regular guest here, he talks about monolaurin a lot as well. And he talks about monolaurin in the context of long COVID and vaccine injury. So, if monolaurin is so versatile and SARS-CoV-2 itself is an enveloped virus, and I saw John was asking what is an enveloped virus, a virus that when its RNA or DNA is exiting our cells, it steals a piece of our membrane as well, or our vesicles membrane, and keeps it with it, that becomes an envelope. So the question is, I can understand with the SARS-CoV-2 that monolaurin is now going to emulsify that cell membrane. But long COVID has different pathogenesis, or vaccine injury has a different pathogenesis. Have you been using monolaurin in that context with positive outcomes?
We have, and this is kind of the big news that I wanted to share with you. It's not just monolaurin. So it started out that I would have patients who I haven't seen in years, often over a decade, and they've been absolutely fine, get COVID or get a COVID vaccine and become sick and come back to the office and treat them, and they became well within a short period of time. And I'd say to them, if you didn't know that you had Lyme before, you'd be diagnosed with long COVID right now. And if you didn't know that you had Lyme before, you'd be diagnosed with a vaccine injury. And you say, what do these two things have in common? And how can they bring about a recurrence of Lyme? When I use the term Lyme, I use it kind of collectively because it's not just Lyme that we find and treat in my practice. Bartonella is probably the other big one, but there's a few others that are less common and also cause chronic infection. But the take-home message is that they weren't hard to treat, that they got better quickly, and they didn't go for long periods of time suffering because they knew they had this history of Lyme, and it felt similar to them, and that's why they came back to the practice. And then after it happened, I don't know, almost 100 times, long COVID patients were calling the practice trying to get in. We kept saying no. And then I said, why don't we just accept a few? And my nurse practitioners, I have two nurse practitioners, they're both great. We started seeing them, and we have found evidence of vector-borne infection in these people. And the other thing that people should know, because they're like, what are the chances that you found vector-borne infections in these people? Asymptomatic infection with these pathogens greatly outnumbers. They're not exactly sure, but there's estimates of up to 10 to 1 I've seen. Who really knows? But we know that it very much outnumbers symptomatic infection. So most people get Lyme, don't get sick. Most people get Bartonella, don't get sick. Why did I almost die from Bartonella? Who knows? Why do I have a hairline that's like, it's just genetics or something. Who knows? But all I can say is that if you randomly test people in the population who are healthy, let's say in New England, 11% test positive for Lyme. They're just walking around with it. The Lyme tests aren't very sensitive, so it's going to be probably something higher than that. It's more of a problem with sensitivity than specificity. And even throughout Europe, it's similar numbers. In some parts of in Poland, these numbers are up of 30 to 40% for both Lyme and Bartonella. So we have some parts of the world that are very high numbers. So if these people get immune dysregulation, could it let the genie out of the bottle for a little while? And so what we've seen is that these patients were diagnosed with long COVID. They were diagnosed with vaccine injury. They came to the practice, and it really didn't take much to get them feeling well again. And this is the weirdest part because they were actually easier to treat than my average patients. And why? Why would they be easier than my average patients? Keep in mind, these are people who are asymptomatic beforehand. I think they had relatively non-virulent infections to begin with. There was a critical period of immune dysregulation, and then they had their asymptomatic infections become symptomatic. And I always wondered why, because I've said on this show before that my patients, I wasn't getting long COVID in my patients, and I still really haven't. And I had another epiphany, I think. I have, at first I thought, oh, it's just early treatment, early treatment. I was, as soon as whatever treatment came around, I was giving all the early treatments that showed efficacy in studies, and I was attributing it all to that. But then when I started realizing that some of these long COVID patients were activated previously quiescent infections, I realized maybe part of the reason my patients also didn't develop long COVID wasn't just because I treated them early, because these are patients who I was actively treating for their vector-borne illness. So if I was giving rounds of doxy or tetracycline in this critical period of immune dysregulation that could happen after COVID, I not just gave them early treatments for COVID, but also kept treating for months afterwards, so they couldn't have any flare-up of Lyme or Bartonella.
That's very interesting. So let me see if I can reflect what you just said. So you're saying that long COVID or vaccine injury could also be patients who have the other chronic infectious diseases, even asymptomatically, there is a flare up of those diseases.
Yeah, and I'm not saying that it's an either or situation. I completely realize that people have different opinions about the ability of SARS-CoV-2 to persist in immunocompetent versus immunocompromised and this and that. And I just think that the vector-borne component, because people who are watching this who maybe don't have a history of Lyme or diagnosis of Lyme may not know just how dismissed the entire field has been. This has been something that has been brushed under the rug. So I think that its relationship to long COVID is equally brushed under the rug because people just don't go there. They don't go to this field. It's a really disenfranchised group, and the long COVID community has been saying that too. They feel disenfranchised, and then when you look at the symptom list of long COVID and chronic Lyme, it's like this eerie overlap. The thing that is different in long COVID patients is because I have friends who are doing research in long COVID now, and they are finding more microclots in the regular chronic Lyme community. So there's something, to the clotting, I do believe for sure. But absent that, just if we look at the infection side of the equation, I think that that part can be treated. Then the clotting side of the equation, people can treat with some type of anticoagulants or
Very
something else.
interesting. So then you said that long COVID or vaccine injury is easier to manage. I know that there are patients who have been suffering for years, year and a half or more. Sometimes they respond to some things, then they relapse as well. And I see a lot of patients who actually recover. So when you say it is easier to manage them, do you have a specific protocol that you use, or it is the same protocol that you use for the other chronic infectious diseases, and that
Same.
just applies here too?
No, it's been the same. So we've found evidence of vector-borne infections, and we don't have a strict protocol for everyone that's the same because I wish you could just cookbook it. It would be so easy. It's best kind of described as heuristic algorithm. So it starts out similar and then it veers off depending on patient response to each patient, and the care becomes really individualized. But it's based on patient response to A. And if the patient doesn't respond well to A, then we go to B. If they respond really great to B, B becomes part of their core treatment, and then we add C. And if C doesn't work, C's out the door, and that's how it goes. And they just zigzag through what they respond to, because it never fails to amaze me what patients with the same diagnosis respond to. There are stereotypes about everything. The stereotypes about, and it's so stupid because they make the stereotypes of treatment for the different vector-borne infections. Meanwhile, the book is like 1/4 written on them. But for example, I have an exceptionally well-documented patient with Bartonella, like very well documented, not just antibody positive, PCR positive, and she came in mostly wheelchair bound from a neuropathy with a biopsy of her nerve showing Bartonella at University of Minnesota, co-localized with her nerve. So you don't really get much better documentation than that one. And she barely had any response to a drug called rifampin. Rifampin is it's a stereotypical drug for Bartonella. But Bactrim, one pill, put her in the emergency room with the worst Herxheimer ever. Herxheimer is a worsening of the underlying symptoms when you treat these infections. And then she got better. It's the only thing that helped her. And before she saw me, she had gone to very, very uh, just extreme measures trying to get well. She'd been to Germany for hypothermia. She's a very nice young lady, and really, just like her world has changed. Like it's the simple little things that if they weren't tried, like I always wondered to myself, if I just thought that that Bactrim reaction was an allergy and it wasn't a crazy Herxheimer, and I never gave it to her in tiny little doses, that would she not have gotten well? So anyway, that's part of the heuristic algorithm, like really taking care to analyze the responses of patients to these things and don't make a quick decision. Like really think about it.
Got it. Thank you very much. Just one quick note. I think your mic may be on the other stem of the headphone. And
The
it
other stem of the headphone.
this one.
Oh, really? Okay, so it's kind of low.
And
Is
it
that
is kind
better?
of, yeah, it was rubbing on your clothing
Sorry.
as well. So
Yeah,
thank
you
you.
know, I'm so smooth with these things. So is that better now?
It is much better. Thank you
Okay,
very
sorry
much.
about that.
No,
All right.
no worries at all. So now let me ask you this question. Let me ask you the recipe. So let's say somebody who comes in with vaccine injury or long COVID, do you actually try Monolaurin as first line, or do you actually look at the overall situation and then go through your learned process, which you have done over 30 years?
We do blood tests first, and we send out massive panels within networks. So it's kind of a big net that we look for in terms of chronic infections, and we do very limited send outs. You know, so like places like Stony Brook, and usually places that take insurance well, and for labs that don't take insurance well, we use a lab called Galaxy frequently, and we do their least expensive test. It's like $150. So so we do that first to get a lay of the land about what we're dealing with. And if we find evidence, typically something would be like, we want to isolate all the variables. We'll start Monolaurin, let's say, if we want to give someone, let's say, doxycycline, we'll start Monolaurin 4 days before doxycycline. Because when people get a reaction to Monolaurin, it's usually quick. There can be this kind of biphasic action of Monolaurin, but it's usually quickly. So, and then, okay, so Monolaurin, let's say a few weeks of doxycycline, some people respond better to tetracycline versus doxycycline. If there's a response to doxy, we don't know, maybe tetra will be better. So for Lyme, for example, per milligram, Stanford and Hopkins both did studies showing that tetra was, more effective than doxy. Like tetracycline has some activity against these persister forms, which are these forms that can't easily be killed, and doxy has basically zero. So, but for Bartonella, you get this weird idiosyncratic reaction to drugs in the same class where one drug will work and the other ones won't. So I had Lyme a long time ago. It was a very mild, moderate case, whatever you want to call it. And tetracycline was so much more effective for me than doxy. It wasn't even a contest. Then I got Bartonella, which almost killed me. I took a lot of tetracycline. It didn't do anything. And then I took minocycline. It didn't do anything. Then I took tigecycline, which is a horrible drug that I wouldn't recommend to my worst enemy. It's an IV drug. It's usually reserved for like ICU. It's supposed to be so strong. Didn't do anything. And then doxy was like the humble chickpea that really worked. And who knew? So you go into it with, you have to like have completely new eyes when you look at all these things and just leave the bias at the door, because you really don't know when it comes to these things sometimes what's going to work.
Very interesting. So
It's
then,
sad though that it's trial and error. I'm sorry to interrupt. I always do, but it is, and patients don't want to hear that, because sometimes the truth is like people want to feel like doctors know everything, and then the wake up call is that we don't. And a lot of it does boil down to trial and error and careful observation, which is, I think, the nature of science. And when the field is kind of an emerging infectious disease field, it's a little bit Wild West.
got it. So I have one more question. Maraviroc, how does that tie in? Do you use Maraviroc in your practice? What is the kind of time when you use it, or phase of treatment, and what are the results if you're using it? What do you see?
We don't use it. We don't use it. We've had a few patients who've come in on Maraviroc, and although I've heard of other patients who have not come into the practice, seen a skewed sample. If I had seen, I wouldn't be seeing patients who took Maraviroc and did phenomenal, right? They wouldn't come to see us. So by definition, the people I see on Maraviroc have not done well. So I recognize that when people come to see me, this is this filtered down sample. So I don't use it. It is a drug that I'm not comfortable with, side effect profile wise. So I have to always say to myself, would I give somebody a drug that I wouldn't take myself? And if I just, no, I'm not going to do it. So yeah, we only use drugs that, I mean, luckily or unluckily, depending on your perspective, I've taken basically every antibiotic known to man, so I know intimately side effect profiles and everything else. And the weird thing is that Monolaurin for me did what massive amounts of antibiotics failed to fully do. It's not like the antibiotics didn't help. I feel like they saved my life and they got me back to functionality. But like, for example, they could never get rid of these flu-like symptoms I would have every afternoon. I would get flu-like symptoms. And Monolaurin completely got rid of that. Completely. And you say, must have been like a biofilm thing. It must have, slowly scrubbed away at biofilms. And that's what detergents do. But no antibiotic is antibiotics aren't detergents. So I really do not withhold my fawning over Monolaurin because it's such a different thing. And then also in part 4 of the Zero Spin, I talk about it. It also has immunomodulating activity, which people talk about its antimicrobial activity because it's very, very important. But the immunomodulatory activity is pretty impressive. They've done a number of various animal studies, and the net result is that it improves resistance to pathogens and immune function.
Got it. So one more question. Do you use LDN as well, low dose naltrexone?
Yes, we use LDN. We've been using that for a very long time. Low dose naltrexone, I very much like its mechanism of action also because it blocks endorphins and then the body thinks it's not enough and it makes more. So he's described LDN as kind of like happiness and exercise in a bottle because it mimics what happiness and exercise do for your immune system. I would love to say that I see a high response rate with LDN, and I don't see that high of a response rate. But when it works, it can work phenomenally. I've seen it change people's lives. But whereas Monolaurin works in about 80% of patients, I would say LDN, to my experience, works in 30 to 40% of my patients extremely well. We do get probably another 20% that are kind of like, I'm not sure, but when people say I'm not sure, I usually take it as a no.
Got it. So Danger Zone has a question, is liposomal good? I think he may be talking about Monolaurin.
I'm not aware of a liposomal Monolaurin. Monolaurin is it's a derivative of fatty acid, and it's really lipophilic. So I don't think it would need liposomal for things like blood-brain barrier penetration. And certainly we see neurologic stuff flare up terribly on Monolaurin. I mean, terribly in a good way, like during Herxheimer's. I mean, so when we talk about efficacy, if your viewers are not familiar with Herxheimer reactions, like, I would never want to give medical advice anywhere, just to my patients. So this is all just general information. But I have to tell you that I've had patients wind up just, a COVID conversation, just patients wind up in emergency rooms and even hospitalized from Herxheimer's on Monolaurin. It's shocking to me how strong Monolaurin can be. And it wasn't toxicity, it was just Herxheimer's, they were fine. But people we went back and forth with the directions in my office and how to give it to patients. First, we started everybody on full dose, and people were calling up saying, we can't take it. These Herxheimer's are horrible. And again, Herxheimer's are exacerbations of underlying illness when there are certain pathogens involved, like certain spirochetes that cause disease, like syphilis, Lyme, relapsing fever, a bunch of other ones like leptospirosis. All basically disease-causing spirochetes cause Herxheimer reactions. So do things like Bartonella and Brucella, which are close cousins. And infections like Q fever can cause a Herxheimer, which is Coxiella. Anyway, so worsening of these symptoms can be severe. And so then we changed everybody to a slow titration up. And then people calling up saying, how do I know if it's working? It's taking so long. So then we had this hybrid thing where we start people on kind of highish doses, depending on their history. And if they don't have a history, we go like 1/4 dose and then half dose and whatever. But the take-home message is to be sure to go back down as much as they need to, so they don't have to suffer. Because one of the other amazing things about Monolaurin is that microbes cannot develop resistance to it. I mean, think about it. In all these years of people washing their hands, and little kids wash their hands so poorly. It's like, I'm all done, and they run away, and they don't develop resistance, pathogens to soap. but bacteria don't develop resistance to soap. So they tried experiments with monolaurin where they gave killing levels, sub-therapeutic levels to bacteria that are known to develop resistance, and they still could not induce resistance. It's the craziest thing. So people
Got
can go up very, very slowly, and you don't have to worry about bacterial infections or getting resistant. It's one of the many, many reasons that I fawn over monolaurin.
it. Got
It's
it.
kind of
So I have a few more questions then.
okay,
So
sure.
first, Danger Zone clarified his question that is liposomal vitamin C good?
Well,
So
I mean, supposedly it is. I've had patients take it, and it's been underwhelming. Like I've had patients do IV vitamin C and have very good results. People have to get this enzyme test before they do that, G6PD, to make sure they don't have a problem with hemolysis from high dose vitamin C. Liposomal vitamin C is supposed to get good blood levels. Having done basically every treatment when I was at my sickest, I did liposomal vitamin C. I did IV vitamin C. I found IV vitamin C to be far more effective than liposomal vitamin C. I even found taking vitamin C every 2 hours at low doses, because you can absorb roughly 200 to 300 milligrams of vitamin C extremely well, and then everything after that, it just falls off. So I was taking about 250 to 500 milligrams of vitamin C every 1 or 2 hours at one point, just trying. And I found that to be more effective than liposomal vitamin C. So I'm
got
not
it.
anti-liposomal vitamin C. It's expensive and, sometimes a little underwhelming.
Got it. Thank you. John says, is coconut oil monolaurin?
Coconut oil is not monolaurin. There is some monolaurin in coconut oil. The primary lipid content of coconut oil is lauric acid, and monolaurin is a direct derivative of lauric acid. There's a small amount that can occur in coconut oil, but it's really tiny. And
Got
lauric acid does have decent antimicrobial activity on its own, but for many pathogens, monolaurin is far, far stronger.
Got it. Mball says, does monolaurin survive cooking temperature?
I'm not sure. I'm really not
Fair
sure. I
enough.
don't know of anybody that's cooked with it. It comes in these pellets. The other one thing to talk about is that the capsules of monolaurin don't work well, and the pellets work well. And this is
Hmm.
something that I was like, well, maybe it's just different doses. So I had patients take equivalent doses in capsules to equal what a scoop of pellets is, because a scoop of pellets is 3,000 milligrams, and each capsule is 600 milligrams. And taking 5 capsules was no comparison to the pellets. I was like, how is this? I don't understand this. So then opened up the capsule, the pellet. I did the taste test. It tastes like dust. I bit into a pellet. It tastes like soap. And I used to eat soap when I was a kid because I couldn't figure out why it smelled so good but tasted so bad. And I kept tasting the next one, like maybe it would be good. And it never, ever was. So it tastes just like soap because it is soap. But for some reason, something happens in these capsules. I don't know if the powder gets oxidized over time, somehow degrades, but it's something that everybody should know, that the capsules, in my experience, do not work well at all. And one of the patients who had a horribly severe Herxheimer monolaurin was taking the capsules for 2 years, getting nothing out of it. And I said, you ever try the pellets? He never did. And it put him in the hospital with Herxheimer.
Very
So,
interesting.
yeah.
Thank you very much. Gene says, could he share what early treatment he has been using for active COVID? Has early treatment protocol changed for the most recent variants? Has he used monolaurin or LDN during early treatment?
Sure. The protocols have changed as we've gone along. I don't run away from controversial treatments just because, people argue about them. I was using hydroxychloroquine in my practice for 20 years. So when they started saying it was poison, it was a big eye roll because I've known so many rheumatologists that it's the single safest drug that they use. So I was not at all scared of hydroxychloroquine, knew how to use it safely. So I did use that at the beginning. And then when ivermectin came out, I used ivermectin. Yeah. And so when Paxlovid came out, I've been using Paxlovid, and I've been combining these things. And when the data came out on metformin, reducing long COVID rates by something like 42% versus Paxlovid's 15%, I've been doing and offering people multimodal combinations of treatments. So I do use ivermectin still. I do think it does not work as well for the new variants compared to the initial strain. I was very, very impressed with ivermectin initially, and then it just seemed that these new variants were so infectious that it just wasn't working as well. I can't say it wasn't working at all, but it wasn't this amazing treatment that it was at the beginning. So, but I do offer my patients that, and um, I've been using fluvoxamine as well. A lot of patients were getting side effects from it, so didn't like it. But we usually want patients to be on a few things. Then we give them a litany of supplements during the time. We give them vitamin C and quercetin and zinc and vitamin. I don't know if I just said C or D, but all the vitamins and melatonin and NAC and glutathione, and it's a whole list that we have, and black seed extract and honey and Benadryl and lactoferrin. I mean, it's a very onerous supplement list. And I say, look, you can choose to take these 15 things or not. I mean, but a subset, it's only for 10 days. If it helps you, I don't think it's going to hurt. So, but it is kind of onerous.
Got it. So once
Supplement.
again, excuse me, for the listeners, this is a educational discussion. There is no medical advice. Please talk with your doctor if you need to take some supplements or medicines. John is asking, what is the so when you titrate the monolaurin
Yeah.
upwards,
Uh-huh.
what is your beginning dose?
So that's what I was trying to say. If someone has a history, some of my patients are very, very sensitive to meds and a very profound illness. And those patients, we're not going to use full dose Monolaurin. We start at like 1/8. And because the Herxheimers happen rather quickly, by the next day, if nothing's happening, we can go to 1/4 and then maybe, 3/4 and what have you. But in somebody who is known to not have a strong Herxheimer history, who maybe gets small little Herxheimers and that's it, those people can start at higher doses, maybe at full dose and go back down if it's too much, or maybe at half dose. Well, I could say that when I took Monolaurin, I did get a Herxheimer within 2 hours. And for me, it consisted of really, really bad chills and esophagitis. You would think esophagitis, that must be a side effect. In the book, I don't think there's anything about my GI symptoms because my story got edited down like 5 times. And everybody wants to hear that I didn't walk and I almost died and blah, blah, blah. But I also developed horrible GI stuff with my illness. I was scoped twice, had every GI symptom you can imagine. And it really, none of them went away until I found antibiotics to get rid of my arthritis. My joints started shrinking and then my GI symptoms went away. And it was all caused by the infection. And it went away and it was gone for years. And Monolaurin brought it back, roaring back. And I was on prescription reflux meds for a little while until that went away. It was just a bad Herxheimer. So it was, but then like I said, it really got rid of my flu-like symptoms finally.
Got it. Thank you very much. Cynthia says, what is the easiest, best source for monolaurin? Is it a temporary or long-term supplement treatment?
There's only 2 brands that I know of that have the granules, and this Lorcidin is one, and what is it called? Ultralaurin is the other, and Lorcidin I think is the original one, and some people favor that one, and others favor the less expensive one. So I think they both work. I think that what I've noticed is very good quality control with Lorcidin, that the granules are always uniform. You never see changes in colors or sizes and things like that. And I can't advocate any of the capsule formulations. And I have no, I don't have I'm not sponsored by these companies or whatever. But yeah, just as long as there's granules. And was there another question with that? Or temporary or long term? Well, for me, it could be both. I mean, for me, I was so happy not to have chills again after years of antibiotics failed to get rid of them that I was like, I'm going to just stay on this. I stayed on it for a year. And during that year, interestingly enough, some of my residual leg pain gotten better. I was doing a lot of research with Duke and Tulane at the time, and I had to go down to Duke and walk the campus, and I couldn't walk more than a couple of blocks without leg pain. I had to stop every couple of blocks. And during that time, I was on Monolaurin, and I just was able to like walk the whole campus, which was large, and with no pain. And it's the only thing I had changed at the time. And I didn't expect that because it didn't flare up. And that's why I think that there may be like this biphasic response. People get like a bit of Herxheimer, but they could be doing something behind the scenes. And again, I think it's because of the detergent action. So that could just take a while for Monolaurin to have a full effect.
Got it. So if you can just give me 1 second, I want to introduce for the newer viewers. Once again, we have Dr. Stephen Phillips with us. He is, I think, country's one of the leading chronic infectious diseases expert. With that, he's an author as well. Here is his book, Chronic, The Hidden Cause of Autoimmune Pandemic and How to Get Healthy Again. I have always requested you and your family to have this book. I have this book. I recommend it to everyone. I send them the links. If I can buy and gift it, I do that as well. The reason why I'm a proponent of this book without any financial ties or commercial interests here, one should know what are the possibilities if some set of symptoms is chronic infectious disease and if these are treatable or how to be treated. And this awareness should be with us from the school time. So anybody who's listening, please have this book. In addition to this, this is Dr. Phillips's Zero Spin Substack. On the Substack, I put the link in here as well. And there is beautiful articles over here. Actually, I'm subscribed as well, and I get these articles too. In this Monolaurin series, I think it is worth it. So with this, back to you, Dr. Phillips. A few more questions. There is a question about, it may be out of the context. I have RA and was on hydroxychloroquine and kidney began shutting down. I stopped and now am on diuretics. I've been getting on the RA wards. What is safe, if anything? This seems to be a very specific question, and we may not be able to answer it, but I'll put it to Dr. Phillips anyways.
So one of my diagnoses actually was rheumatoid arthritis. I mean, they diagnosed with spondylitis and tried to diagnose with rheumatoid arthritis. They kind of like projected it at that point. The RA warts, do you mean the nodules and the elbows? Could I get clarification on that question?
Okay, so Tinkerbell, if you are hearing this, can you please update us?
Unless it's something, because hydroxychloroquine is not a true immune suppressant. It doesn't. People usually don't get opportunistic infections on it. I've not seen people get papillomaviruses on hydroxychloroquine in the past.
Got it. So question Mark Schaefer says, I saw a video with a GAT gastroenterologist that said long haulers were low on bifidobacteria in the gut. Do you recommend supplementing for bifidobacteria?
I don't think it's a terrible idea, but I think one thing that people should know about the microbiome is that it's painted, I think, by media in a very broad stroke that it's just a friendly bacteria. There's no such thing. Bacteria out for their own interests, and that's all. And if we happen to benefit by their presence, it's just our luck. So in chronic inflammatory patients who've never taken antibiotics, their microbiome is messed up. If you look at patients with inflammatory joint disease, they don't have great microbiomes. And because people a lot of times think that taking antibiotics is going to screw up the microbiome, but in the book in Chronic, we refer to the microbiome as pathobionts, which is a more appropriate microbiology term, because they're pathologic under certain circumstances and they're symbiotic under other circumstances. So really, if the immune system is functioning properly, we have to keep the microbiome at this distance, let's say, and it's close enough to get the good stuff from it, but it's not too close that they attack us. And if it gets too close, they behave very differently. And then it's too far. If we don't have enough of them, we don't get the good stuff from them. So it is this weird, balancing act and dance. But I think that's one thing. And I've tried to put this on different Facebook posts, and no one seems to get that nuance too easily. They always think that the antibiotics are going to destroy the microbiome. Meanwhile, the antibiotics we use in my practice, first of all, we use a lot of antimicrobials that aren't true antibiotics. Monolaurin is an obvious example of an antimicrobial that's in no way an antibiotic and doesn't damage the microbiome. And then in terms of true antibiotics, we use ones that have limited activity against the microbiome. And then we use lots of antimicrobials that don't have any activity against the microbiome.
Got it.
Things that aren't antibiotics.
Got it. Thank you. Tinkerbell followed up. So you had asked that are these nodules the RA warts? And Tinkerbell said yes, and I was told to use Voltron.
So they're the what do you call it? The rheumatoid nodules, which I had
Correct.
also. When I was sick. It's just the answer I think is getting at for me. The answer is getting at the source of the infection. There are, I forget how many total now. I think 12 randomized controlled trials showing the antibiotics work for rheumatoid arthritis, and placebo doesn't. I don't know how many you need, to say that there's an antimicrobial, action here. The rheumatologists are very, very quick to say that it's not the antimicrobial activity of the antibiotics, it's the anti-inflammatory activity. But about half of those articles specifically use antibiotics that are devoid of anti-inflammatory activity. Not all antibiotics have anti-inflammatory activity, just some. And when they do have anti-inflammatory activity, it's often not that strong. Advil is usually stronger. So I treat RA in my practice in a very, very different way. We don't focus on the effect, we focus on the cause. And if somebody has to take drugs to suppress the effects, to just suppress the inflammation while they're getting at the cause, they definitely should, because you don't want anybody to suffer. And if people come in and are on immunosuppressants and have a diagnosis of RA, we never say, oh, go off immunosuppressants. We know exactly what's going on. Go on antibiotics. Like, we would never be so arrogant. We say, look, you're doing the standard of care now. Obviously, it's not working well. And there are risks to it. Being on long-term immunosuppressants has risks of getting cancers and risks of getting opportunistic infections. It's not a completely benign thing. So it's all about patient autonomy. You have to really, really, really explain the risks and benefits of everything. And people are smart by and large. If you take a little time, they can understand any of these medical concepts and help people make good decisions for themselves. But that's how we play it. We don't stop people on immune suppressants right away. Um, yeah, but a lot of times what we find is that as people get better, they naturally feather off the immune suppressants on their own because they don't want to be on them.
Got
That's
it.
usually what happens.
Got it. Thank you. A few more questions. CK says, I know we are talking about inflammation. When I had COVID in October 22, the 10-day headaches felt like my brain was on fire. I now have brain fog, lose words, and extreme tiredness at times. Suggestions?
Well, this is kind of what we're seeing in what we talked about earlier, is that we're seeing some patients that have come in with chronic illness after having had COVID or having had the COVID vaccine, and evaluating them for previously asymptomatic vector-borne infections, things like Lyme and others, finding evidence for them, treating those infections, and seeing these patients get well. And I treat about 100 or so, I'd estimate, in my practice at this point. Enough for me to speak, I think, confidently on it. At first, it was just an intuition, and then it kind of, it kept gathering evidence. I said, okay, now it's enough people that I could say, I'm pretty sure this is part of it. May not be all of it, but it's definitely, in my view, it's part of it.
Thank you very much. Alive in Heal says, sorry I joined late. Did the docs discuss methylene blue to treat chronic UTIs or lung bacteria conditions, please?
We don't use methylene blue in my practice. It's one of those things that goes in the category of would I be scared to take it myself, so we don't use it for my patients. It's a carcinogen for rodents, so we try to stay to medications that are not to be known carcinogens. That's not
Got it.
saying that it may not have activity and be helpful for some people, because I have heard that it can help in some patients, but we don't use it.
Got it. Jill, I'm going to show your question, but I don't think it is something that we can really advise on. So Jill says, back to vax injury. After one shot, I'm running Pfizer. Do you recommend completing vax 2? And what about starting over with Novavax series?
Hi, Joe. I'm not giving out vaccine advice to folks. Even in my practice, we don't. We just say follow up with your primary care doctor. Yep.
Jill, Svetlana says, is there any anecdotal evidence of any of this helping a bone marrow transplant patient who has GVHD?
Any of this helping a bone marrow transplant? That's a really fascinating question.
And I don't have an answer.
Yeah, I don't have an answer, but I'm just wondering. I mean, Monolaurin has and LDN both have unusual, and I don't know that you can predict the reach of their immunomodulation. I wonder. I can't say that it's going to work, but it's a discussion. I think if I had a GVHD patient come in, it's a discussion I'd probably have. Like, you know, it's outside my area of expertise, I would say. I'm sorry.
Got it. Thank you very much. So Loop Duplicate says, I slept in. No, did you already talk about, we'll be talking about monologue.
Yeah, yeah. That's fine.
Primal says, have you seen an increase in mast cell disorders after COVID vaccine, and what would you suggest to help diagnose of such?
We have, but it's not higher than what I've seen in that's kind of commensurate with my general population. Like we see type 2 / mast cell stuff frequently in my patients. And there are many infections that I don't know if people know this is common knowledge that mast cell disorders are always a result of something, and infections are very adept at doing it. And like I was talking to some MIT researchers about 6 months ago, and they said that of all the bacteria they'd studied, Lyme bacteria were the most adept at inducing mast cell activation compared to any of them. And then I know we were speaking briefly about valley fever, which is like the Lyme of fungal infections, something present in the Southwest, in the deserts, in California, and California and Arizona have the most in the country. And it frequently induces this incredible mast cell activity and type 2 immune response. And it turns out it's part of the disease process. It's part of what allows this permissive state for the infection to continue. And I mentioned this case of this little boy who was literally dying of valley fever. They were giving him massive antifungals, could not get him better. And they added Dupixent, which turns off the type 2 immune response, aka mast cell activation. They're subsets of each other. And the boy, made this miraculous recovery and is living a fairly normal life now, long-term follow-up. And I think he still gets treatments, but he's not in this critical state. So so I do. The answer is, sorry to go on tangents. The answer is yes, we do see it. It's, like I said, commensurate with the high levels that we see in my patients. So I'm not seeing it over and above. It's not like everybody that comes in has more mast cell activation than the patients that we're seeing all the time. It seems to be pretty much on par.
Got it. Thank you. Danger Zone says, is lumbrokinase good for long COVID? So do you use lumbrokinase or nattokinase?
We do. We use mainly nattokinase, and we haven't. So out of the three, serrapeptase I think has the most anti-inflammatory activity. If we wanted to choose that, we don't use it so much from the perspective of biofilms and clot busting, even though a lot of people talk about it in these things. So we definitely had it. It's not one of these broad recommendations we do, but if people have heart disease in their family or risk of heart disease, we really start talking about nattokinase for them, and always give the warnings about potential bleeding, even though it's small risk. Baby aspirin can do that too.
Got it. Alive in Heal says, why is Lyme so prevalent in the New England versus rest of the world?
There's actually a bunch of hotspots that are just as prevalent as New England. I've done 2 speaking tours throughout Europe and in Scandinavia. It's like almost tears, like just leaving them. How much Lyme they were so debilitated by these chronic infections there. There are parts of Europe that in blood tests score higher than New England for sure, but it just happens to be high in New England, and it's also high in the Northern California. It's high in the Upper Peninsula, like of Michigan. There are spots where it is high throughout the country, and then there are Lyme cousins that are high in the rest of the country. That it's not actually Lyme disease, but it's their cousins to Lyme. So they keep finding Lyme is a Borrelia, and they keep finding new Borrelia all the time. And so, for example, in the South, they have Borrelia lone stare, which is not test positive for Lyme, but it causes a rash and it causes chronic, illness and neurologic problems and joint and the whole bit. But it's not Lyme disease, technically. And they have other subspecies of Lyme that are more closely related, like Bacilli. Then they have this one called Mayonnaise in the Midwest, named after Mayo Clinic. It's getting almost absurd because there are so many Borrelia that, yeah, Lyme disease is much more common in New England, and Lyme plus everything else is actually pretty homogeneously distributed, not just around the country, but probably around the world.
Got it. Thank you. This is an interesting question. John says, does Dr. Phillips test for MTHFR gene mutation? In his experience, are those with mutations more susceptible to chronic illnesses?
Yep. We usually test for homocysteine, which is the downstream effect of the MTHFR, and I do treat when patients have high homocysteine. We do have a naturopath in our sister practice who does check the genetic mutations, and she prefers to treat everybody with MTHFR. But keep in mind that 1 out of 4 people has one of these genetic mutations, and I just don't know. Like, if the homocysteine is high, I definitely do treat. If it's not high, I've not. So I typically don't check the gene because it's partial penetrance, and just treat if the homocysteine is high.
Got it. Couple of more questions. I know that we're almost at 1 hour. So thank you very much for your time.
My pleasure. Thank you.
So one question, Jean Oliveira says, besides Monolaurin, what other non-pharmaceutical antimicrobials has your office used for enveloped viruses and vector-borne bugs? So non-pharmaceuticals, I believe. Non-prescription.
For viruses, it's going to be hard because there aren't many non-pharmaceutical things. I mean, so there's talk about, we use a lot of oil of oregano, liposomal oil of oregano, and there is some activity of oil of oregano against viruses, but it pales when compared to Monolaurin. And in terms of the non-pharmaceutical antimicrobials that my office uses, they're myriad. So we use a lot of fluconazole, which is an antifungal. And fluconazole was discovered by accident in Germany years ago by Dr. Schardt, Schardt, who had chronic Lyme, and he couldn't get rid of it, and he had neurologic features, and he ended up doing IV and getting a really bad fungal infection and taking fluconazole for the fungal infection, and poof, his Lyme got better. And then he did a little study and looked at patients who failed IV Rocephin for Lyme and still had neurologic symptoms, and he treated them with fluconazole, and they all got better. 8 got all the way better, and 4 got partially better. And then Johns Hopkins tested it in the test tube and said it was really powerful against Lyme. And then they did another study of antifungals of the same class against Bartonella, and many are powerful against Bartonella. And they actually did not include fluconazole in that study. So I called up the guy who did it and say, why did you include fluconazole? And he did. It was just kind of medium against Bartonella. It wasn't super strong, but against Lyme it's very strong. So that's just one example. We use a couple of herbals, and we use a lot of drug called Mepron, M-E-P-R-O-N. It's Tovacone. Mepron has historically been stereotypically used, I should say, for babesiosis. But we've had 2 separate researchers study it and show that it kills B. burgdorferi, Lyme bacteria, in the test tube. And neither one of them have published it. And one of them was also Johns Hopkins, a private communication that I have from the researcher. But, and there's a few more. And then we use some focused antibiotics as well.
Got it. Thank you so much. One last question.
Sure.
And that is from Lisbeth. Lisbeth is saying, any comments about babesiosis?
Sure. I mean, babesiosis can be asymptomatic, or it can kill people, just like the many other vector-borne infections. It is weird to think that they virtually all span this crazy spectrum from no symptoms to deadly, but that's how they are. And for example, 3% of the population around Boston, Massachusetts area tests positive for babesia, and so it doesn't always kill people, obviously. There's some data about new species of babesia and cross-reacting antibodies between a couple of different species, and the jury's out on what the best treatment is for these things. And for the book, we interviewed a lot of people who are babesia specialists, and they basically said, which the problem is the literature doesn't support chronic babesiosis like it does chronic Lyme and Bartonella and Coxiella and tularemia. So There's data with Lyme where they've treated patients for literally years of antibiotics and grew Lyme bacteria alive. So there's no such data like that with Babesia. There's a few cases of people who got treated with the standard thing like zithromaximepron, relapsed, got treated again, and then didn't relapse. And that's it. So one of my nurse practitioners was going for her PhD, and she said to me, like, I don't know, a few months ago, she's like, there's no such thing as chronic Babesia in the literature. I was like, yeah, I know. But a lot of people come in and other doctors that are in my field talk about chronic babesiosis like it's an accepted thing. And then they think, well, you're, not taking chronic babesia seriously. No, I'm taking everything seriously, but I'm a very show me the data kind of person. And I would definitely change my opinions if there's data. So far, there hasn't been really good data on it. It's not to say it can't happen. I can tell you that out of all the herbals that I tried when I was sick, I must have spent $5,000 on herbs that didn't work. And it really enforced my prejudice that herbals were not so great. However, I took liposomal artemisinin, and that caused a huge Herxheimer, and then market benefit. And people say, well, that's a Babesia, treatment. There's no such thing. It's like saying Mepron. None of these things are laser focused. It's like saying Mepron is a Babesia treatment when two separate institutions have found that it kills Lyme in the test tube. And then Hopkins published artemisinin kills Lyme in vitro, which was shocking because the mechanism of action should be like all over Bartonella. So all I can say is that when I treat patients, we change the course of treatments based on outcome. And we try to cut out the treatments. That's the philosophy of the fair shake and the expiration date. You don't want to beat your head against the wall, taking months and months and months of stuff that doesn't work. Because the people that come to see me have been on 5 years of treatment and aren't well. It's usually because the doctors kept putting them on the same thing that wasn't working. And I say, why did they do 9 months of this? If it wasn't working after 6 weeks, I don't get it. And that's the thing that no one understands. They just say, I don't know. They just said it takes time. I'm like, no, it really doesn't take that much time. It takes maybe time to get fully well. It doesn't take time to know that something's really working. It takes a short amount of time to know that something's really working, that it has promise, and then it could take longer to get fully well.
So thank you so much. Thank you very much for coming in. Thank you for your time. Thank you for the insights. And thank you very much for connecting the dots for the long COVID and vaccine injury with the vector-borne diseases and the possibility that these conditions can be managed quickly. There are so many who are depressed, who are disappointed, who are losing hope. So I love to have these kind of talks where we can provide hopes, we can offer some ideas as well. So my question to you is, if somebody wanted to find your clinic, what should they do? How do they find you?
Well, this website, StephenPhillipsMD.com. The phone number is 203-544-0005. But, it's pretty easy to find. Been in practice for so long. So.
Got it. So with this, once again, thank you very much for coming in. And thank you from all of us KoolBeens.
Thank you. Thank you very much. Bye.
Bye-bye.